Good morning, everyone. We would like to thank you all for signing in on our communicable disease webinar that we're having. We have our medical consultant, Dr. Joyce Smith, here that's going to give a great presentation on the communicable diseases. If you have any questions, you know the drill, raise your hand or type them in. Victor will read them off, and we will do the best that we can to answer all your questions today. Thank you, and I'm going to turn it over to Dr. Joyce Smith.
Thank you. No problem. I'm often called Dr. Joyce. Good morning, everyone. Again, I'm happy to be here again to speak with you regarding communicable diseases. Let me tell you a little bit about myself before I get started. I am a MD. I trained here in Chicago at Rush. I went to the University of Illinois Medical School. I did a fellowship in ambulatory pediatrics at Cook County Hospital. I've spent most of my career working with community health centers. I've been medical director of Circle Family Care, Friend Family Health Center as well. So I've been practicing pediatrics for about 30 years. So just wanted to know a little bit more about myself. I think that we didn't go over my background the last time that we were together. So just so you know who you're talking to. I've worked with Head Start several times in the past. I've done several presentations. If you have worked with Head Start for a long time, you might have worked with me before, as I did previous OSHA trainings and other types of medical pediatric trainings as well. So again, thank you for attending, and I hope that you find this a valuable experience. So we'll go ahead to the PowerPoint. We're going to discuss communicable diseases. And what I did was put together a not an all-inclusive list, but some of the things that I know that you will probably see in your day-to-day working with pediatric children. So why don't we just go ahead and have the first slide, please? Okay, so in the child care or group setting, the children are at increased risk for infectious disease spread. Amongst the children, generally the ones who are younger than 2 are going to have a higher rate of infections. And as the child has been in daycare or Head Start or group setting for maybe 6 months or more, then that rate begins to go down. Then rates decrease after 6 months. Children are 2 to 18 times more likely to catch an infectious disease than someone who is in a non-group setting. So again, you might have noticed maybe when you first went into a group teaching that you might have caught more infections. As pediatricians, when we first started our training, we catch a lot of colds because there's so many viruses around that will your body has not yet recognized, and so you may be susceptible to those viruses. Also in a group setting, go to the next slide. Also in a group setting, the teachers are at more risk. So you have the same window, but the window of the teacher is about a year actually in coming across most of the viruses that you're going to run into in your first year of working with a group of students. And the spread depends upon the environmental and host variables. So maybe the season of the year, you're going to have more strep infections in the fall and winter. You're going to have more colds also during that time. You know, flu season is starts kind of like in October, ends end of March, April or so in there. So, you know, that's a time when a lot of people are sharing germs. Hygiene practices, of course, if you're washing your hands, as indicated, then you're decreasing your possibility or your risk. The immune status of the host, so if the host has a low immune status, then they may be more susceptible and maybe get more infections. And it also depends on the virulence of the germ or the pathogen. Because if it is something that's highly contagious and you've not been immunized against it, then you're likely to possibly get it. Next slide. Okay, so this is a short list of diseases that are that we know are spread more likely when children are in a group setting. and that would be otitis media, ear infections, pneumonia, diarrhea, hepatitis A, which is similar to diarrhea because that's one of the symptoms of hepatitis A is yellowing eyes and gastrointestinal symptoms. Streptococcal infections, that might be strep throat or that might even be a skin infection. Rotavirus, which is again diarrhea. So diarrhea is something, you know, that really puts us or you all at risk. And then chickenpox as well because that's a skin and a contact disease. Next. Conditions for transmission. We mentioned this at our last OSHA training. In order for one to catch an infection, there must be certain conditions met. So one, the pathogen, which is the germ, it must be present. So I can't catch a cold, per se, if I don't come across the virus. So there's no way that I'll catch it. So the other thing, there has to be a adequate quantity present. So if you're in a room with someone who's coughing, the window is open, then some of those germs are going out of the window and into the open air and into the ambient air. Versus you being in a closed room and you're coughing, someone is coughing, then those germs are maybe not being recirculated or not being recirculated as well because the window isn't open. And then, so you might have adequate exposure. And then again, you have to be susceptible. That means that if I did not get my chickenpox vaccination, then perhaps if I treated someone with chickenpox, then I'm susceptible because I've not been exposed to it. However, I've had several chickenpox vaccinations as well as the chickenpox. And then there must be the correct port of entry. So chickenpox is spread by air droplets as well as direct contact, not spread by other mechanisms. And say hepatitis A also is spread by fecal-oral contamination, and so that is actually how you get it. You're not going to get hepatitis A necessarily by being in the room with someone, but you may get hepatitis A if you change a baby's diaper and they happen to have that virus and you didn't wash your hands properly. So that would be the portal of entry, and then you went to have lunch and ate some hepatitis A. Next slide, please. All right, then there are the modes of transmission. We talked about them mostly already. Airborne, the upper respiratory tract infection, the common cold, mini strep infections, those are airborne. And then droplets. So when one coughs, not only is the germ airborne, but it drops on the desk in front of you. Then maybe your hand is there, maybe your pen is there, and then you touch the droplet. Direct contact as well, and fomites. Fomites are items which transfer germs from one person to another. And a very common fomite would be a pen or a telephone or a keyboard. So that's why you want to make sure that those items are being cleaned, or maybe you're not sharing your pen so much, so that you can decrease the possibility of sharing germs. And then bloodborne pathogens, we spoke about that quite a bit about a week ago, so I won't go into that. And then vector-borne, so say malaria caused by a mosquito, that you have to have come across that particular vector in order to get that condition. So we're going to start off by talking about upper respiratory tract infections. And the pathogen or the germ that causes a cold is generally a virus. There are many types, and so that's why we catch so many colds. The average child will catch about 8 to 12 colds in a year. Some children maybe catch as many as 16 colds in a year. And that doesn't necessarily mean that their immunity is low, but it's just that they've not seen those viruses before. And as we age, our body recognizes viruses, some of the viruses, and then we don't catch as many colds as we age. Symptoms of a cold are going to be runny nose, congestion, headache, cough, maybe muscle aches, or maybe little to no fever. The mode of transmission is droplets and respiratory secretions. So if you touch someone's respiratory secretions or you share a pen, then you might in fact catch that cold. The incubation period for a cold is about 1 to 3 days. The period of contagiousness is 1 day before and up to 5 days after the start of symptoms. So oftentimes when someone has a cold, they've already spread the germ. So when a child in the daycare setting or in the Head Start setting has a cold and they don't have a fever, oftentimes that's not really a reason to send them home because everybody else has already been exposed. We're practicing the appropriate hand hygiene. We're using our tissues for coughing. And so we're doing all the appropriate things, all the appropriate mechanisms to prevent the cold from being spread. So the management of a cold is supportive. That means that perhaps if the child is febrile or if they're losing fluids by way of having them running nose, you want to replace those fluids and you want to just support the child's regular daily activity. The prevention is done by prevention of spread. Again, cover your cough, appropriate hand hygiene, teach the children, of course, to cough into their elbow and use tissue and wash their hands after they've used the tissue. And they're only excluded if fever is present. Now, oftentimes I've gotten patients who come and their child has a cold and they want antibiotics. And we all know that antibiotics are not going to help a virus. So there's no treatment, no medication per se that one should have for a common cold. And we also need to stay away from over-the-counter cold preparations, particularly if children are younger than 4 years of age. It's been shown that these medications have side effects. Most of them have been studied for older people, not for younger people. So, and if the child is going to have a cold, regardless of what you're going to do for the next 7 to 14 days, you might as well not put your child at risk for taking those medications. So again, the next condition we're going to talk about is viral pharyngitis, and that's simply a sore throat. And the pathogen, there are many viruses, again, that cause a sore throat. And many other things actually can cause a sore throat. Just dry air may cause a sore throat. Allergies also may cause a sore throat or kind of an itchy throat. So symptoms would be gradual onset of a sore throat with a runny nose, cough, maybe diarrhea, maybe fever. The mode of transmission, again, is respiratory and droplets and close contacts. Management is going to be supportive. They may have a fever, so you may want to give fever medication. And if they have pain, then pain medication might be indicated. Generally, these are going to be people who can complain of a sore throat, so those probably are going to be someone who's older than 2 or 3 as well that would identify that they're in pain. Okay, respiratory conditions. The next one is streptococcal pharyngitis. So streptococcal pharyngitis is also an infection of the throat, and it's a sore throat essentially, but it's caused by a bacteria, and it's caused by group A beta hemolytic strep. That's what the GABHS stands for. So symptoms are going to be a little bit different than the viral pharyngitis. The onset will be more rapid. There'll be more pain with swallowing. Fever may be higher, headache, muscle aches, and tonsils will be enlarged, and lymph nodes would be enlarged as well. However, we must be careful because on physical examination, there is really no way to absolutely determine if what you have is strep versus viral, which is why generally when someone comes to the physician or their practitioner complaining of a sore throat and they have a fever, then we're going to actually do a strep screen to determine if they may be positive for beta hemolytic strep. And if they are, if the screening test is positive, then they would be treated with an antibiotic. If it is negative, most likely the provider, the appropriate thing to do would be to swab the throat and actually send it to the culture, because the tests are pretty specific, but they have a low rate of perhaps missing 3 or 4 out of 100 cases of strep. So it's important that we actually take the time to try to find out if it's actually strep or not. Otherwise, we would be giving antibiotics inappropriately, and this is what we want to stay away from. The mode of transmission, again, is respiratory and close contacts. Incubation period is 1 to 3 days. A problem with streptococcal pharyngitis is it may develop into scarlet fever. Period of contagiousness is, if treated, then the contagiousness is decreased within 24 to 48 hours. And so when we treat a child with an antibiotic, and that antibiotic is most likely going to be penicillin unless they're allergic, then we will allow them to go back to school within 48 hours of having started treatment. Strep is almost universally sensitive to penicillin, again, unless you are allergic, and that would probably be the medication that's taken. However, untreated, one is contagious for maybe about 10 days, and they probably are thinking they probably have a virus and maybe haven't gone to the doctor. And the problem with untreated strep is that it may lead to complications such as rheumatic fever, which may lead to kidney problems as well as heart problems. So it's important that if a child who is 2 or 3 and older has a high fever, complains of a sore throat, that they actually get checked out to see if perhaps they have a strep throat. Particularly a younger child probably has other school-age children, and strep is more, incidence is higher in children who are 3 and older. Management is antibiotics. If given within the first 9 days, that decreases the possibility of leading to the possible rheumatic fever and possible heart problems. All right, so just have a gander. So this is what we look at, and I just want to show you what we're looking at when we're looking them out. This is nonspecific pharyngitis, and it can be produced by many pathogens. Could be strep, could be virus. You know, I don't know. So if I were seeing this person, then I would actually swab their throat to determine if it actually is strep or not, and follow the protocol that I just mentioned. Next slide, please. Okay, this is someone also who has a sore throat, and you can see at the top of the mouth there, the little dots, the little red dots are petechiae, which are little small hemorrhages. Though they seem to be more closely associated with one actually having strep, but again, there are plenty of viruses that may cause this as well. But if one has a high fever and has these petechiae, we have a much higher suspicion that they may actually have strep. Next. This is another throat. One of the things that you might have heard in the past is that strep, sometimes they have exudate or they have white patches on their throat. So this is someone who has really bad sore throat. He has a petechiae on the soft palate as well, and it looks like they have a little strawberry uvula, little bumps there too. He must be pretty miserable. So this might be a strep, or it might be simply a virus like Epstein-Barr, which causes mono, might be the reason for this child having exudate on their tonsils. Okay, upper respiratory infection, moving on to the next upper respiratory infection. CROUP. And I really miss being in the classroom because I want to know how many of you all have seen a kid with CROUP. I guess you can chime in and say, I have. So it's an upper respiratory tract infection with a partial obstruction that causes noisy breathing, that is stridor, and respiratory distress. It causes a bark-like cough. They kind of sound like a seal. It mostly affects children 3 months to 5 years of age. So we're going to take a listen to what a croup cough sounds like. Poor baby. Oh. Let's see how she's breathing, or he's breathing. So he's having stridor. He's having hard time getting the air in as well as out. So you hear that extra sound. You hear that particularly if the child is upset, but this child is particularly sick. Usually they don't get this sick. So that high-pitched sound, that's the stridor. Okay, that's hard to look at. I cannot see the presentation. Someone
we're watching the video.
Oh, they must have just come in. So, so why don't you just roll it back so we just hear that cough again, and then we won't listen to him suffering. Okay. Okay, so that's no fun. So, so that's CROUP. That's an upper respiratory infection with partial obstruction. Causes a bark-like cough. Mostly affects children 3 months to 5 years of age. Why don't we go to the next slide, please? Okay, the pathogen is usually a virus. Sometimes you have a superinfection with the bacteria as well, and it's pretty bad. So symptoms start off like a mild cold, and for the first few days, and then gradually they increase and develop stridor and the bark-like cough. Fever can be low or maybe a high as 102. Generally, it's not going to be 104, but you know it might be. The problem with CROUP, as you see, that the children can become hypoxic and need hospitalization because they're not able to move air. But most of the time, children are able to be pretty comfortable with CROUP if you allow them to be comfortable. If they're upset and crying, then they're going to have more stridor. So you want to just make them as comfortable as this little child. You can see that I'm sure if his mother was anywhere around, she wanted to hold him and hug him, but probably the best thing to do is just kind of let him relax so he doesn't have to put up much work as necessary to breathe. And the mode of transmission is respiratory. Okay. So while we're here, I'm going to show the pertussis. I want to show you one more and this is of a child who actually has a whooping cough. So that is the whoop when she's firing in. And it just doesn't get better. Okay. We don't need to see her. I can barely stand to see her suffer like that. So that is a presentation of whooping cough. So whooping cough, I don't have a slide for it, but I just want to talk about it for a minute because it's a preventable disease. As you all probably know, then we give immunizations at 2 months, 4 months, 6 months for whooping cough, and as well as boosters. And so it can, it's a pretty devastating disease if one gets it, if a child gets it. Generally, the people who are passing whooping cough around are going to be teenagers, and so that's one of the reasons that the immunization for adolescents has changed, and so it now includes a Tdap, and Tdap has the diphtheria, tetanus plus pertussis in there so that we can stop that. Or someone maybe who has never had immunization, an older person, but generally it's been the teenagers and maybe the young parents that have been passing it on to their children or to other young children. So it's really important not only that the children be vaccinated, but that adults be vaccinated as well. Okay. Okay, so management of CROUP usually can be managed at home. It's important to keep them calm. We already talked about that. So that'll decrease the stress of having to work to breathe. They may have to go to the emergency room if the distress worsens. There are some medications that can be used as racemic epinephrine that can be used that will actually shrink the supraglottic tissues so that the child would be able to breathe better, and sometimes they may even need to be intubated. But again, usually it's going to be a mild to moderate type of condition for the child. Okay, moving on to the next condition. This is an ear infection. So I know that if we were in a room together, we'd be raising our hands to discuss or to say that we know someone who's had an ear infection, or our children have had ear infections, and maybe some children have ear infections really frequently. And so, we'll talk a little bit about why that is. So it's pretty prevalent. 80% of children have at least one episode of otitis media. The peak incidence occurs in the first 2 years of life. Most cases are self-limited, meaning that if no antibiotic or anything like that is given, generally they're going to clear that problem themselves. If the pathogen is a virus or a bacteria, and again, there's no way on physical exam to know if the culprit is a bacteria or a virus, but most of them actually are viruses. We have a plan of watchful waiting. So if a child is older than 2, they maybe have a low-grade fever, they're not really extremely uncomfortable, then we may watch them to see if their condition worsens and then decide to give antibiotics. However, if someone is actually really sick with a really high fever, then probably it's best to just go ahead and treat them with an antibiotic. Otherwise, you're going to be taking care of their fever and pain. Okay. Risk factors. There are several factors that increase the risk of a child getting otitis media. Age is one. The highest rates are in infants who are 6 to 20 months old. And I guess we want to keep the current color scheme. I don't know, maybe a gremlin said, you should use a different background. So anyway, so the age, so younger children are going to have more ear infections. The anatomy is different in a smaller child because the face is rounder. The structures of the inner ear and the throat and the back of the throat are closer. So sometimes it's thought to be started as maybe a throat infection, and then it spreads back to the structures of the ear. or sometimes there is mucus, and the mucus also has the opportunity to have exposure to bacteria and then develop a ear infection. Smoke exposure, this is a preventable risk factor. It's known that children who are around smokers tend to have more otitis media, more ear infections. So you should talk with your parents and try to make sure they're not smoking around their children. Pacifier use. There seems to be a small increase, but really nothing significant in pacifier use. I wouldn't tell someone to throw out the pacifier if that's something that their child really enjoys. And it appears that breast milk has a protective effect, so that a child who is raised with breast milk for 6 months of their life, they tend to have fewer ear infections as well. The next condition we'll talk about is conjunctivitis. I know that we would have a room full of raised hands as well if we're talking about conjunctivitis. And when you're doing your morning checks and your kids are coming in and somebody's coming in with an eye that's kind of not so cool looking, kind of red, and, you know, mom says, oh, he's fine, he's fine. And then another child is coming in with red eye and then it's got some pus all around there. So I know you're faced with this probably almost on a day-to-day basis. So conjunctivitis or pink eye can be caused by a virus, can be caused by bacteria, can also be allergic, and can be caused by other conditions, such as you might have heard of Kawasaki, which is not a bacterial infection. However, its presentation often starts with pink eye or conjunctivitis. Okay, so conjunctivitis is highly contagious. That's because little people like to spread their germs by touching their eyes and touching you. Yes, and touching their eyes and touching you. So hand hygiene plays a big part in that. Also spread by the use of fomites, meaning that if I have a eye infection, I rub my eye, I use my pen, I say, here, use my pen to sign your name, then you rub your eye, then you may in fact have a conjunctivitis in the next couple of days. There is also allergic conjunctivitis, and that is not contagious. Generally, allergic conjunctivitis is going to be bilateral. Sometimes bacterial conjunctivitis will be unilateral. Okay. Symptoms are going to be redness, pink eyes with white or yellow discharge for bacterial conjunctivitis. They may have lid, not ild, eye pain. So the mode of transmission is direct contact. Incubation period is about 1 to 3 days. Period of contagiousness is until the redness resolves, or it's been determined that they're non-contagious, or they're using an antibiotic. And again, I use a 48-hour rule when I allow children to go back to school once I treat them for a bacterial conjunctivitis. So this is more likely to be a viral conjunctivitis. You see, there's redness, but there's no mucus, or not mucus, but there is no thick pus-like discharge there. So this is most likely going to be a viral conjunctivitis. Now, this is just as contagious as any other, so you know you're likely to spread. So that still may be a reason to exclude a child, because then although it's viral and it's going to go away, you don't want everybody in the room to have conjunctivitis, and parents won't be happy. Next slide. Okay, now this is where the money is. This child has bacterial conjunctivitis and has a thick greenish yellow discharge. Generally, people will complain that the eyes are stuck together after they've gone to sleep, and they have to use a cloth to wipe the eyes. So this child probably would benefit from an antibiotic drop. But however, most conjunctivitis will still even resolve if they don't receive the antibiotic drop. But it's, that will decrease the the longevity of the disease for a day or two. So it'll be a day or two shorter if you use the antibiotics. Another conjunctivitis, pink eye, with you see the yellow crusted material around the eye. Okay, communicable disease. Okay, management, again, hand hygiene, prevent the spread to the other eye by not rubbing your eyes, and prevent the spread to other people. Prevent the progression of viral or allergic bacterial conjunctivitis. Prevent the progression of viral or allergic to become bacterial, because oftentimes when we have an allergic conjunctivitis and it itches, and so you rub, you have dirty hands, you introduce dirt into the eye, and then you develop a bacterial conjunctivitis. Same thing with viral. Sometimes they progress on as well. So the treatment would be bacterial would be antibiotic drops. Viral is self-limited, hand washing, and generally they're going to still be excluded until the redness goes away. And allergic conjunctivitis, the treatment would be topical or eye drops that are antihistamine. Common skin presentations. Okay, so we're switching now from upper respiratory and eyes to the skin. So first we're going to talk about measles. And measles, again, is a preventable disease. And children are required, particularly those that are in school, are required to have measles vaccinations. Let's see, let's go. Let's move to the next slide. Okay, so the symptoms of measles, there's a prodrome where you just really kind of don't feel well for 2 to 4 days. Then you develop a fever, harsh cough, watery eyes. That's another disease that gives you a conjunctivitis. It's a virus, but it's not like having a single conjunctivitis by itself. Then you get a blotchy red rash, and that starts about 14 to 21 days after you've been exposed. It usually starts on the face and around the neck, and then it spreads to the rest of the body. The rash lasts for 7 to 14 days. Measles is still around. I think that there was a publication sent out by Illinois Department of Public Health February 24th reporting that there was a child who had measles who had come from, I forget where they come from. However, they're in Illinois. So that means that somebody in Illinois has been exposed to measles. So you want to be careful as well and be watchful.
We posted that publication on CSD website.
Right. Mm-hmm. Okay. So measles is also highly contagious via direct contact as well as actually respiratory. So direct contact with oral and nasal secretions. If you have not been immunized against measles, or if you're handling contaminated clothing. Incubation is 8 to 12 days, and that ranges from 7 to 18 days. The period of contagiousness is slightly before the prodrome and until about 4 days after the rash develops. Complications may include pneumonia, meningitis, otitis media, and death because of the above, particularly the meningitis, possible complication. So it's really important to make sure that those children are immunized on time. And if they are exposed to measles and they're too young to be immunized, then a child who is over 6 months can be immunized with the measles vaccination. However, they're going to have to be immunized again when they turn 12 months, and again at 5 years, as any child would have. So they can receive a immunization early if we know that they've been exposed to measles, as well as immunoglobulin if we think it's a good possibility that they would actually catch it. Next. Okay, so this guy is not so happy. Intensely erythematous patches of the face with spreading, that spread inferiorly onto the trunk. So it kind of starts in the face and the neck, and then it spreads down. Some of the little papules are coalescent, and so they kind of look like more like blotches instead of individual papules. Next. Rubella. German measles, the pathogenesis of German measles virus, and it's also known as the 3-day measles. And it is a mild disease with mild fever and swollen glands, usually lasts 2 to 3 days, and generally to the child is of no consequence. However, the risk to the public is that a child with German measles may expose a mother who is early in her pregnancy, and that would have devastating effects on the infant. So therefore, we immunize children against the rubella vaccination, and since we have the convenience of having them all, the measles, mumps, rubella, all in one vaccination, so it would be a good thing to make sure that the children are vaccinated with that. Its contact again is with respiratory droplets, and incubation period is 14 to 21 days. The management would be pretty much supportive as well. There's not going to be any medication or any antibiotic that you would give, and we want to make sure that everybody gets immunized as well. Next slide. Okay, so this is German measles. It looks a little different. It's more confluent, more non-specific of rose pink macules and papules. Macules are flat, and papules are raised. So I guess you would say more of a papule is a bump. A macule is something that's there, but you can't feel it, you can see it. And so many diseases, particularly things that are measles, like we call them maculopapular rashes, and that's what that means. Next. The other thing that I forgot to mention also when we were on the measles slide is that measles is reportable. So in fact, if you come across somebody that has a documented case of measles, or you think that someone has measles, then it should be reported to the Illinois Department of Public Health, as should be varicella. That's what the asterisks are there for, to remind me to tell you. But the first one didn't work. Okay, so the pathogen here is the varicella zoster virus. Its incubation period is 10 to 21 days. There may be people who haven't seen anyone with chickenpox because it's gone, the incidence has gone down quite a bit since the immunization has been given and since it is required for school. Symptoms: sudden onset of mild fever, itchy rash, starts as a maculopapular rash and progresses to vesicles, which are like, looks like a papule with water in it. And then they crust, and then more develop. And one of the key factors in determining if one has measles just on a clinical impression is, I'm sorry, not measles, but varicella, is that their papules will be in different stages of healing. So they say if you have measles, all the measles bumps are going to look like measles bumps. But the chickenpox, some are going to be just coming out, some are going to be crusted, some are going to have fluid, some are going to be flat. They're going to be in all different stages, and so that's what we call one of the pathognomonic signs of measles. The average person has about 300 lesions. The number of lesions and the course is much worse if you get it when you're older. So someone older than 12 or an adult who gets varicella is going to be pretty miserable. Sometimes they have like 1,500 or so pox lesions. Next. Okay, the mode of transmission, again, direct contact with respiratory droplets and contaminated items. Touching the skin of the vesicles, so those little Vesicles are teeming with viri. So you want to make sure that if you're touching somebody with chickenpox that you probably are going to need to wear gloves. Period of contagiousness, 24 to 48 hours before the rash develops until all the lesions are crusted, which maybe takes about 5 to 7 days. Management complications, it is reportable to the city. Okay, there's my reminder. Notification, so of course you're going to notify parents if someone in your class has varicella. You can, if someone is susceptible to catching varicella, if they receive the immunoglobulin VZIG within 96 hours, then that might prevent them from also catching varicella, as well as immunization. So they should get immunizations as soon as possible, as well as the VZIG. Next, please. Okay, an unimmunized child with varicella, and you can see that he has quite a few things going on right there, and his nose has like a lesion that's actually cratered, so it's probably going to scar. Then you can see vesicles, and you see they're different sizes, and it doesn't really look like, maybe it looks like some of the ones on the upper part of the nose here might be crusting as well. So you can see that they're in all different stages of development and progression. Next slide, please. Okay, this is someone who, the previous slide was of someone who had not been immunized, and so they got full-blown chickenpox. This is immunization, this is a varicella in someone who had been immunized. So even though varicella, you may receive the varicella immunization. Thank you. One may still develop varicella because the immunization itself is pretty labile, and it needs to be kept at a particular temperature, and if it's not, then it may lose some of its potency. One really does not know. Plus, the vaccination probably protects maybe 80 to 90% of the people it vaccinates, and then others are going to have maybe a breakthrough or maybe have a subclinical case of varicella. But the reason for getting the immunization is that it prevents you from having a severe case, like the poor baby did on the previous slide. Fifth disease, erythema infectiosum. I put this on because kids are coming up with fevers and rashes, and I know that you all look at them in the mornings, and you need to be able to determine not necessarily what it is, but if it's something that you need to exclude them from school or at least separate them from the other children. And this is a rash that's caused by parvovirus, B19. Kind of actually looks a little bit like measles, has an incubation period of pretty long, 4 to 28 days. Usually it's benign and doesn't really cause much of a problem, but it makes the child look like their cheeks have been slapped. And then, so it starts in the face, and then it progresses as you get more and more maculopapular areas, and they coalesce and develop kind of a lacy appearance on the arms. The mode of transmission is respiratory, nasal drop-ins. The period of contagiousness is right before the rash. So once somebody's developed erythema infectiosum, everybody's been exposed because you don't have symptoms before the rash develops. Next slide, please. So, not so bad. He's not having a hard day. Except, he's got the red cheeks, like he's been worked over a little bit. But, otherwise, it's a pretty mild illness for a child. Next slide, please. All right, and then as it moves down, you can see that there's has like what they call a lacy type of a pattern on the arms and the trunk. Next slide. Yeah. Okay, the next condition is hand, foot, and mouth disease caused by Coxsackie virus A16. Symptoms are mild with low-grade fever. The children develop ulcers in the mouth and blisters on the hands and the feet. Mode of transmission by direct contact. Period of contagiousness is before the lesions appear and for several weeks after. So they look like little vesicles on the hands. And then, they're generally on the hands. They're generally on the palms of the hands, the plantar surface of the feet. And sometimes they're also on other areas of the body, like maybe the knees or the elbows as well. So deep-seated vesicles with erythema involving the palmar surface of the hand. Next slide. This is the mouth part. You see he has an ulcer in his mouth. This is usually pretty painful as well. So they may come in with a fever, they may come in and they're refusing eating. And I guess I say come in because I'm thinking in terms from the medical perspective. Now, they're probably not coming to school like that. But, when we see them, they are coming in complaining of pain or not eating or having a fever. Next slide, please. Okay, so this is the papules as they look on the knee. Next. And then here we have them on the plantar surface of the feet. Okay, so warts. Warts called VERRUCA. The pathogen is HPV, and I'm sure everyone's heard of HPV, human papillomavirus. There are many, many strands of human papillomavirus, so we're not talking about the human papillomaviruses that are responsible for cervical cancer or oral cancer or anything like that. These are different HPV viruses, but still they're HPV. Usually benign in children and adolescents. So usually they catch them and then they can take care of them. The body can actually take care of the not the virus, but the virus. Yes. Incidence is highest in children and adolescents. The incubation period develops about 1 month after inoculation. Symptoms are slow developing growth, sometimes painful, particularly if they're on the feet. Usually they're less than 3 millimeters in size. Mode of transmission is going to be direct contact, auto-inoculation, and fomites. Auto-inoculation means that you have one on your hand and you scratch your back. Then you've got one on your back. So if you see someone who has warts, you want to make sure that they're not scratching. The best thing to do, usually warts don't take up a lot of space, so the best thing to do is to actually cover them so that there's not skin-to-skin contact with warts. Period of contagiousness, okay. There are no limits, so as long as there are the warts there, then they can be contagious. So they can be covered to avoid direct contact. Management, most of them will disappear by themselves within a couple of years. There are other treatments like liquid nitrogen, salicylic acid, which is what is found in compound W. And what you do is put the bandage on the wart and you leave it on there for some days, about 5 days or so. Pull it off, and then you're able to core, like with a pumice stone or something like that, to actually pare the wart down. And then it might take several applications of that before the wart actually goes away, or one can wait the 2 years and cover it up. And then there's podophyllin, which is a dye that is applied, and it causes the warts to involute. Next. So there are multiple types of warts, and these are just a few. They're flat, they're filiform, meaning they kind of stick out like a finger. They're plantar, meaning they're on our feet. They're common, meaning they can be everywhere. And then they're periungal, meaning that they could be under the nails. Next. Okay, so this is a picture of a common wart that's on the nose and a filiform wart that's beneath the nose. This is a wart. Can't really tell from this picture that it's a wart, but it's a wart on the tongue. So the mouth is also involved. Oh, yes, there it is. Thank you. Okay, and here are, let's see, gotta go back one. Okay, plantar warts. So you can see them, and these are probably painful on the bottom of the feet. Next. These are subungal, meaning that they're beneath the nails. They're actually on the tips of the fingers, and then they're growing under the nails. Let's see, with the extension under the nail plate. So again, so this is how you can auto-inoculate if you have them there and then you're scratching. So probably you should treat that. Next. Molluscum. Molluscum contagiosum. I see kids oftentimes, particularly toddlers, young children that have molluscum contagiosum. It's caused by a virus. Incubation period is about 2 weeks or so. Symptoms occurs mainly in children and people who are immunocompromised. They are discrete, pearly to flesh-colored dome-shaped papules that look umbilicated. So they almost, if you will, look like chickenpox without the craters and the crusting. Anywhere on the body, they average about 6 to 9 months. Again, that means that the body will take care of them, but they may persist for years. And again, they're contagious. You can auto-inoculate yourself, and you know it can spread. And then in some cases, they're plentiful. Like sometimes around in the groin, then you know they may really replicate in the groin and diaper area. Next slide, please. Mode of transmission: direct contact, fomites, and auto-inoculation. Period of contagiousness, they may be present for years. So, excuse me, as long as they're present, then there's a possibility of them being contagious. Management is usually self-limited. You can manage them by scraping them off, and that would be the treatment of choice for them. Let's see if we have some. There's one. It's really small. The picture makes it look like larger because you don't really have an orientation, but excuse me, it's maybe about 3 millimeters or something or so. It's really a small dome-shaped nodule. Next. So, and here is what I said, and sometimes it kind of looks like, it can look like chickenpox without the different stages. Some of those are crusted because he's been scratching them because, you know, they itch as well. And so you can see he probably has been rubbing around his eyes. He also has some on the other eye as well. Yeah. So we're moving on to fungal disease of the skin, another one that I'm sure we're all very familiar with. Tinea capitis, which is ringworm of the scalp. Tinea corporis is ringworm of the body. Tinea pedis is athlete's foot, and tinea versicolor is a generalized fungal infection on the skin, looking different than tinea corporis because tinea corporis is brown, and tinea versicolor is more macular and scaly. And then intertrigo, that's when it's involved in skin folds. And that isn't necessarily tinea. That could be candida, which is the fungus that's responsible for many diaper rashes and diaper dermatitis. Okay, so. Tinea capitis. The pathogen is a fungus, a dermatophyte, that affects the skin. It really probably has a longer incubation period. Symptoms: hair loss, black dot hair, black dot appearance, meaning that the hair breaks off right at the hair shaft, so it looks like there's a little black dot there. Diffuse flakiness with little or no hair loss is another presentation. So you can either have the hair loss with the black dot hair, or you could have really flakiness of someone thinking that they really have bad dandruff, and actually they have tinea capitis. And then you can have a severe inflammatory reaction that would produce a carrion that looks like a pustule. The mode of transmission is direct contact and with fomites, meaning sharing combs, brushes, shares. So when you're in the movies, always put your hood on or something, so so you don't catch what's in the chair, as well as hats and other things that one would share on their head. The period of contagiousness is ongoing without treatment. So as long as you have it, it's going to probably continue to grow. Maybe the body will take care of it, but it will probably, it's a very slow-growing, stubborn infection. And if anyone has ever had to have a child who's been treated for tinea capitis, you have had them to give medication that is really tasting yuck, 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 for 6 to 8 weeks. So sometimes the kids have a hard time taking the medication because it doesn't taste good. But it is the only way to cure tinea capitis. You can put some topical medication on it, and it might get better, but it will not cure it. So the only way to actually cure tinea capitis is actually going the oral medication route. Next slide. Black dots. So just demonstrating the black dot pattern. And next slide. Okay, so this is a carrion. So you can see that there is sparse hair, and then there is this boggy nodule-like structure. And so that is a carrion. So there's a lot of liquefied material inside of that, and it's kind of an exaggerated reaction of the body to the fungus. So sometimes one might need to have take a steroid to decrease the inflammation. Sometimes they're super infected with the bacteria, and sometimes one may need to give an antibiotic. But for sure, you have to have an oral antifungal medication to treat this. And it's more likely to lead to permanent hair loss versus the simple tinea capitis. Next slide. Fungal disease of the skin, tinea corporis, that's the on the body. Again, fungal dermatophytes. Slower incubation period. Symptoms: round, reddish, scaly areas that progress to centrally clean areas that may be millimeters or more, or centimeters in size. Spread by direct contact, or perhaps you can catch it from an infected pet, dog or cat. Period of contagiousness: as long as the lesions are present, you are contagious. Management is going to be a topical antifungal unless they're so spread all over the body that you can't keep up with them topically, and then you might take an oral medication. But generally, you're going to be able to treat an antifungal with an antifungal medication for several weeks, though. Again, it's slow growing, and so it takes a long time to cure it. So small lesions can be covered to decrease the possibility of spreading. Okay. When we finish, we may go back. I may have a slide of tinea capitis or tinea corporis that I can show you. I just wasn't able to get it into my presentation, but Victor may be able to help me out with that. Okay, so tinea versicolor. This is a fungus that grows on the skin. It's noticed more likely in summertime because one tans, and the area that's affected by the dermatocyte does not absorb the sunlight and does not tan. So hence, people will notice that their skin is getting lighter in areas. But it's called tinea versicolor because on some people, people who have a lighter complexion, it actually may cause the skin to become dark as well. Okay, this is another tinea versicolor. The person is a dark-skinned person, so you can, it's pretty, apparent of the lightness of it. And this is treated with, you can treat it topically with an antifungal medication for a couple of weeks. You can treat it with salicylic acid application for a week if you wash with it daily. Then it will decrease. But it tends to occur in certain people. Not everybody catches tinea, even though one may be sitting right next to you, although it can be spread by direct contact. But it just tends to be more so in some people than others. Next. Scarlet fever. Okay, so we're going to talk a little bit more about bacterial skin problems. Scarlet fever, which is not so much as a problem with bacteria in the skin as it is scarlet fever is the bacteria that's in the throat that's led to systemic symptoms, and then abscesses and impetigo. Okay, so we saw the throat when we talked about pharyngitis earlier in the talk, and we saw some throats that looked like they might have been strep throat. So with strep throat, sometimes it goes on to develop scarlet fever, and with that there is a red sandpaper-like rash, and it looks very goose pimply. So sometimes that's the only thing that brings the patients in, is that the parent has noticed that they have this red rash. And after a few days of this rash, it begins to desquamate. So you can see that that's why the skin looks kind of ashy on this child, because the skin of the of scarlet fever is beginning to desquamate. Next slide. Okay, here is again post scarlet fever desquamation on the hands, and sometimes it can look pretty severe. Next slide. Okay, so here we have a carbuncle, and as you know, there are people who tend to have boils, or they develop MRSA, methicillin-resistant staphylococcal Staph aureus, and and sometimes they have recurrent boils. And so this is what one looks like. This one isn't really big. You can tell from the orientation. This is his chest, and there's a smaller one that is just superior and lateral to the bigger one. So probably a satellite lesion. There's some other little papules around that may be developing into abscesses. So this would need to be treated by lancing, and that's the main way to actually treat a carbuncle or abscess, is to lance it so that the pus can come out. And then most people also use an antibiotic, but actually studies show that the most important part about taking care of this is actually to get the pus out. This is impetigo, and this is a strep. It can be a strep infection of the skin, or it can be a staph infection of the skin. I'm good. Or it can be a staph infection of the skin. And this is called bullous impetigo. So you can see these little round lesions. These were once vesicles, like big vesicles with fluid in them, and then they break. And then you see the desquamated skin around them. So, and the child may have a fever, and this is painful. So there are multiple tender erythematous patches with a peripheral collarette representing the remnants of the blister from the vesicle. actually, it's not a vesicle. When they're really that big, they're called bulli or bullae. So it's no longer a vesicle. Okay. Bacterial skin disorder, impetigo. These multiple lesions, they are not bulli, but they kind of look like cigarette burns. Sometimes children who have developed this have been suspected of child abuse because you have the circular lesions on the skin. But they're not. You know, they're strep or staph lesions, and they can be spread by direct contact, or they can be spread by auto-inoculation. So again, if you scratch yourself and you have a boil somewhere, you scratch yourself one place and then scratch somewhere else, then you may end up with a boil or some skin infection there. This can be treated locally as long as it's like in a small area, but if it spreads all around the body, then one may need to take oral antibiotics. Or if it's suspected of being MRSA, then you're going to be given oral antibiotics for it. Infestations, head lice and scabies. Okay, so our pathogen for head lice is an insect, pediculosis. Eggs hatch in 7 to 10 days. Symptoms are scratching the head, identification of nits, which are little, what looks like maybe rice, small little rice attached to the hair, and they don't come off easily, so you can't rub them or you can't brush them off. The mode of transmission is direct contact with a person who's been infested with them, or their clothing, or some other article in which it's on. The period of contagiousness is as long as there are eggs that are not treated. The management would be an application of permethrin cream, leave it on, and then wash it off, and then probably a second treatment in about a week or two. Next slide. Okay, so here are nits that you can see, and I think in the middle, on the right side, that is actually, and also, yeah, in the middle, right there in the middle is actually a louse. Yeah, there. Okay, and then there's another one just right and just straight across from where that one is. Yeah, right there. You see that? Yeah. Okay, now these may be walking. The nits won't move. Nits won't move, but the lice may, you know, move around. So when you're looking at your children in the morning, and I know the hair inspection is part of the morning assessment, then this is what you're looking for. So this comes with, this is managed, again, with the shampoo, and then there's a special comb that you use to comb the nits out. And again, in a week or so, it may take a second treatment. And sometimes they fall into the eyelashes. Okay, let's move on. Scabies. So this is the part of the talk that makes people itch. Okay, so scabies is an arthropod. It's not actually lice. It's actually like a little animal. It's a mite. So, and it's an obligate human parasite, meaning that it doesn't exist outside of a human. So it can't live on anything else other than a human. Incubation period is 2 to 6 weeks. The first time one gets scabies, it shortens if you have repeat cases, 1 to 4 days for future infestations. Symptoms are going to be scratching, itching, and then you're going to have a what we call papulous squamous lesion, which means kind of like a scaly, bumpy rash. Next. Mode of transmission is direct contact with infested individuals, possibly also with fomites. So if they're on clothes, they could possibly be in chairs. Period of contagiousness is until 24 hours after they've been treated. And the management is going to be, again, an application of permethrin, but this stays on the body for about 8 hours. And younger children will leave it on shorter times, maybe 4 or 6 hours. Sometimes we will end up having to treat infants as young as a month old with scabies once they come home. The incubation period for it is about 30 days or so. And then you wash it off in 8 hours. And then consider another application, particularly if you see new lesions coming. But there should be no new bumps once you've applied the permethrin. Next. Okay. And so that's what it looks like. That's electron microscopy of it. You can't really see it with the naked eye. Well, you can look on. You can see it under a microscope, so you can scrape the skin and actually get it, get some skin on the slide, and then look at it under a microscope. But you won't see it like this, not with all the details. Next. Okay, so this is scabies, and in kids, it tends to like the skin folds. Actually, no, in kids, it actually tends more to like the trunk. In older kids and in adults, it likes the skin folds more. So when you're treating someone for scabies, then you want to make sure that you apply the topical medication into the skin folds pretty liberally, because it likes ankles and wrists and between the fingers and places like that. And you can see it's like a papula, so it's like a little bump, but they're bumps, but they're also scaly. And they itch, of course, like the dickens. Sometimes you might have a reaction, and an allergic reaction, and you end up with a rash pretty much all over the body that's very itchy. Next. Okay. So this is skin with scabies. Scabies walk under the skin, and they lay eggs and create what we call burrows. So on the slide on the left, you can see what looks like a semicircular area. So that is a burrow. Can you circle that for me? Left slide. Yeah. Yeah. Okay. Right there. Okay. And then lower down on the left, there's just another patule, and then there's another burrow on the other slide as well. So that's one of the things that we look for. Maybe we don't always see it well in children, but generally in adults you can see the path of the burrows where the mite has been walking beneath the skin, depositing feces as well as depositing eggs. Next. Okay, and so this is the skin, again, of someone who has scabies, and they've got a pretty bad case. Okay, so these are the conditions that I prepared for you. I guess we can maybe look at some other slides. Were there any questions or any concerns that people have?
Not any questions right now, but I encourage anybody who has a question, go ahead and type them in, and Dr. Smith will answer them. You can type them in the question box or the chat box, or go ahead and raise your hand and we can unmute your mic or your telephone, and you can go ahead and talk to Dr. Smith directly. Did you want to see if we can get some of those pictures that we couldn't get earlier?
Yeah, why don't we?
While people type their questions in?
Right, we'll just show a few more pictures that I wasn't able to technologically manage to get in my presentation. Okay, let me see. What didn't we see? Oh, flea bites. Flea bites.
Flea bites.
Yeah, they are. Okay, go up to the top. Up to the top. And then Candida. Candida diaper dermatitis.
Okay.
Right there. Yeah. Open that one. Okay. So this is a fungus, Candida. Grows on the skin. It's a common cause of diaper rash. Generally, we can tell that this is a Candida rash is because it usually has a border around it, a pretty distinct border, but then you see like little bumps, as you see on this baby's stomach, and those are like the spores that are kind of rolling away from the basic fungus. And also in Candida diaper rash, the skin folds are involved. So if you were to open the groin area of this baby, you will also see redness inside there. Versus irritation, which if there's irritation, there won't be redness inside this inside the skin folds. Okay, intertrigo. That's right. That's the next one. All right, intertrigo. So intertrigo, this can be caused by a bacteria or a fungus, but this particular case is caused by a bacteria. It causes breakdown in the skin fold. So sometimes babies will have this on their neck, under their neck, particularly because, you know, the really chubby babies don't have much of a neck, and so it's dark and it's wet under there. And, you know, or if not everybody really knows all the crevices babies have that you have to clean up. And if somebody misses this crevice here, you can end up with something like this. And so the treatment for that would be a topical antifungal medication. Okay, oral, the next Candida. Okay, so this is oral thrush. And this baby's probably pretty miserable with having so much thrush. There you can see it's on the mouth and it's on the tongue and it's also inside the cheeks. Spread by direct contact. Young babies may get oral thrush just by virtue of going through the vaginal canal, because usually there is yeast in the vaginal canal, and so they get exposure in that way. You know, because their immune status is not, you know, if they're less than 6 months, immune status is not so good, then, you know, they may more likely be, they more likely may develop an oral thrush. An older child usually won't develop an oral thrush, but an infant may do that. So you have to make sure that they take mycostatin. And the medication is they're going to take the medication until all the spots go away. And remember, these are microscopic as well. So not only do you just give it until, you know, for a week or two, but you have to make sure. So you want to make sure that all the spots are gone and that you give it for another week after that to actually make sure it's cured. You have to get rid of all the old nipples and from the bottles, or you have to boil them, or you have to throw them out. And also you have to buy a new binky in order to actually get rid of this. Let's see, we saw hand, foot, and mouth. Okay. Flea bites, that's like midways. Up, 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 right there. Yeah. Okay. So flea bites are going to be on the lower part of the legs, most likely, because, you know, fleas jump, but not that high. So, I mean, if they're jumping off an animal or something, you know, you may have an animal that may have fleas. So they're going to be concentrated around the lower part of the leg, around the ankles, that sort of thing. You know, they're raised, but they have a circle of redness around them. Okay, I think there's another flea bite. Okay, this is a flea bite, and this is the breakfast, lunch, and dinner sign.
And snack.
Yeah, and snack. Okay, So you see this because, the flea has been, take a bite here, hop, take a bite there. So you see this with fleas, but you also see this with bed bugs because they kind of walk, along, la-da-da-da-da, bite, and then a little later, la-da-da, bite, and so, that's just kind of classic for a flea bite or actually a bed bug bite. Okay, bed bug, let's look at that one. There's our friend right there, if you've not seen one in person. It looks like it's about the size of an apple seed. And it actually, if you're not close up on it, then it actually probably looks like an apple seed, but then it crawls. As you know, Chicago is, I believe, #1 in bed bug infestations. So generally, you're going to have someone come out and actually check for bed bugs. They don't come out during the day. They come out at night. They live in crevices, and they can live for a while as well. You can get rid of them, or you have to, in order to get rid of them also, you have to get their eggs. So they're susceptible to steam. So if you have a steamer, then you can steam your mattress and steam your sheets, and that should help you to get rid of them. Okay, let me see. Do I have? Let's see. I don't have roseola. Let's go down about 6, right above, right there. Yeah, roseola. Okay. Roseola is actually a viral infection along the lines of Fifth disease, but the classic roseola picture is a young child, maybe an infant, someone probably is older than 6 months or so, that has a really high fever repeatedly every day for 3 days. And so you're at your wit's end and you know that there's something really serious, and then this rash develops, and then the fever goes away, and they're fine. So in the daycare setting, you probably aren't going to see much of this because you're going to exclude the kids who really have a high fever. But if they come back and they say, well, they had roseola, that gives you an idea of, what you would need to be concerned about, which really would be nothing much because the exposure has already happened. Okay. And let's look at the scalded skin. Right there. Scalded skin. This can be caused by staph or strep. So this particular one is caused by staph. And sometimes you'll see this in the diaper area. And what these are actually bullae that we talked about before that have broken. And so it's pretty painful and pretty red. And so the treatment for this would be an oral antibiotic. Let's look at the next scalded skin that's right next to it. Let's see. Oh, I guess that's the book I got it from. But if you look sideways, you'll see that there is also a strawberry tongue. Now we know that there's a strawberry tongue with strep infections and strep throat, but also with staph infections. And you see this baby that has that denuded skin, that desquamation up top, has also had scalded skin syndrome from actually toxic shock syndrome.